everybody. My name is Katie Weldon, and I am the Programming Director for the Mississippi Gulf Coast Chamber of Commerce, and I'd like to welcome you to our Singing River Health System updates. Thank you so much for being with us this morning. Just to go over a few things, the mission of the Chamber is to connect, inform, advocate, and develop. And what's that looking like these days? It's looking like these virtual events, which we're averaging about 3 a week. So thank you for taking the time to be here and showing your support. We really appreciate this community gathering around. So thank you so much for being here. Just to go over a few housekeeping things, if at any time during this update you have any questions, if you hover over your screen, you'll see at the bottom the Q&A box. At any time, please ask your questions there and we'll try to answer them as fast as we can in the allotted amount of time. Also, you'll see a chat box. Feel free to chat with us or chat with the attendees and the panelists, but also be aware that this is public information. So anything that you type in there can be downloaded afterwards, even if you send it privately. Just the things to keep in mind. Moving on, I'd like to thank our panelists for being here, Mr. Lee Bond, CEO of Singing River Health, and Dr. Randy Roth, Chief Medical Officer. Thank you so much for taking the time to be with us today. And I'd also like to thank Ms. Georgia Story and Ms. Jackie Robinson for their help in helping us set this up. And on that note, Mr. Lee, would you like to get us started?
Sure. You're welcome, and thanks for having us. So I'll give you a few stats on where we are today. Through yesterday, since this thing started, our first case on March the 9th, we have 212 positive cases in our community. We've got several of those. How many are still hospitalized? I think 19 still hospitalized. We've done over 2,400 tests. We've taken over 6,000 calls on our hotline, the 809-5044 number. We've done over 8,000 televisits, and we've had, unfortunately, there are 9 people rather that have lost their battle with this insidious disease since it started, but you know, we've had over 200 victors, and yesterday we were able to discharge somebody who had been intubated. So anyway, it's we feel like we've had some, you know, with any war there's going to be a few lost battles, but ultimately more victories, and we are going to win the war. So that's that. But I'm Lee Bond. My title is Chief Executive Officer, but Sarah calls me the brand evangelist. I love Singing River. I bleed Singing River blue. And Dr. Roth is our Chief Medical Officer. And why don't you tell them a little bit about your background in addition to being Chief Medical Officer? You also run the program.
So I'm an internist by trade, and I started our hospitalist program in 1999. It was the second oldest program in the state, and I think the best one. And I'm proud to say that I'm the CMO, but I'm also proud to say I'm an active internist who's been on the front line taking care of these people and their families, and it's been an honor to do so.
He's a Chief Medical Officer and a real doctor still at the same time.
Absolutely. Never take that away. That's the fun part of my job.
Great. Well, my name is Rachel Seymour Kiesling, and I serve as Operations Manager over at the Coast Chamber. We do have some questions that were sent in prior to this, so we're going to go through some of those. And then, of course, give some folks some time to put some questions in the Q&A box. So the first one is, what is the process for follow-up on medical appointments after someone was treated at the hospital or quarantined at home?
I'll take that one. So right now, every COVID-positive patient that's discharged, we call them or do video visits post-discharge until it's safe to them to get back to their primary care doctor. Right now, it's being handled both by our navigators, which you can talk about in a minute, but also by the discharging service, the IPS services, nurses. I think longitudinally, these folks will end up seeing their primary care doctors and our pulmonary critical care doctors because, again, this disease is all of 5 months old. So there may be some sequelae down the road that we need to look into. Like an example of that would be, we are seeing a lot of folks with this disease who get thick blood and have blood clots. Do we need to treat them longitudinally with blood thinners or aspirin to prevent a long-term side effect from this disease? Again, heart failure and pneumonia, we know what that has been like for years of knowledge and research, but now with this, we're really basing it on 5-month history. So we're going to keep track of all of our COVID-positive patients and make sure they're plugged into our network once we return back to normal and everything opens back up.
I'm very proud of what they've done. Great program. Our doctors have been, you know, traditionally you see a doctor in the doctor's office, but with this, there's a whole different level of interaction, phone calls and video visits. And I feel like anybody who has tested positive in Jackson County has been really had their hand held from A to Z, whether it's the doctor, the nurse, or as you mentioned earlier, we have actually assigned patient navigators who help them with anything and everything. We've had some folks yesterday that we helped that just needed some basic necessities and needed some help with that. And our communities come together and help beyond just the typical medical needs with our COVID positive patients.
Because most of these patients are going to need follow-up for the other things that brought them to the hospital. So we really got to get them plugged back into their diabetes and hypertension and obesity and renal disease. And oh, by the way, I had COVID. And what is the data going to show that we have to do extra for these patients to keep them safe in the future?
Right. And so kind of to elaborate on what that timeline looks like for follow-up and really where does that handoff happen between the hospital and the general practitioner long-term? How do you foresee that progressing?
It's a little different now because right now the state's still asking our primary care guys to do everything they can via telemedicine or kind of a drive-by visit. One of the beauties about our system is that we're all in the same electronic medical record. It's called Epic. So all of our doctors can tie into everything we've done in the hospital, which is a huge advantage amongst all of our primary care guys and ladies. So when they have a patient of theirs that comes into the hospital, the next day that patient is on their list where they log on to the computer and they can follow the entire stay in the hospital. Our nurses are calling these patients, making sure their needs are met. A lot of these patients are getting followed up by home health care services, checking their oxygen level, and then eventually they'll plug back into the primary care in person as well as their subspecialist. So that's kind of what it looks like from here.
Great. So will the hospital visitation policies ease up soon for the non-COVID patients? We know what a stress that puts on families and how that, certainly is an unintended consequence of what's happened. So do we look for that to happen anytime soon?
I'll touch on that one. So basically, yes, we do think it's going to ease up soon. We hope it is. We want people to see their families as much as they want to see them. It's as painful for us on the inside as it is for those on the outside. What we have been able to do, again, the technology that has come through has been great. People are learning to use FaceTime more than ever. Our IT department provided iPads to our nursing units for people that don't have that ability, and we've been able to find unique new ways for people to communicate. But we expect, and there's a system that is in place where it's a tiering system. As the world opens back up, the visitation policies will be relaxed. We're prepared to do that at the right point in time. But we've got, and then if somebody needs surgery, we assigned a new position, surgical ambassadors that help people. So if someone is here and normally they have a whole family come in, now they're allowed one essential visitor under the federal or state guidelines. We also have the ambassador that will go and help update the people that maybe are out waiting, outside or telephonically externally. So we've found ways to manage. It's not ideal, but we hope it opens back up soon.
But I will add, I do think moving forward, there are going to be changes across the continuum of healthcare in terms of how safe is it, even post-COVID. Is it really safe, someone who just had a bypass surgery, for them to see their 3 grandkids who may have RSV or bring an MRSA into the hospital? So I do think moving forward, it's not going to be, the hospital's not often a joyous place, but
yeah, it's going to be different.
It's going to be different. I don't think it's going to be as sterile as it is now where nobody can come in. But if you think about it, if you have a procedure done, the last thing you want is someone who may be infectious in your room, unbeknownst to them. So it'll look different. I will reassure you that everyone in our COVID floor, if there's a big change in status, like a happy thing, they're able to come in. The folks that we've had that have passed, we've brought their families in to be by their side, fully PPE'd and protected. And that's important for y'all to know because it's not like we let them maybe pass without people in the room.
And most people understand this, but just in case there's someone who doesn't, the visitation policy restrictions, they're there for the benefit, not necessarily of the person visiting, but the other patients in the hospital. The hospital is probably one of the cleanest places on earth. It's cleaner than most homes. This infection seems to spread mostly through our contact tracing through homes, not through the hospital. But the situation is such that the people that are in the other patients in the hospital, out of respect for them, if there's someone who's severely immunocompromised or has some severe comorbidities, for their protection, you don't want to take any risks. So if you've got the loved one who's in that situation and someone else is just having a gallbladder issue, you don't want that person to accidentally come in the hospital and somehow or another create a situation for the person who's immunocompromised. So it's for the best, unfortunately, for the protection of patients. That's what we're here for, is to keep people safe. And I do think in the future, I think he's right, it's going to be a little different going forward. There'll be more stringent checks.
Right, and as there should be, and thank you for clearing that up, because I think there is a perception out there that folks are, by themselves at the end of their lives, and it's, certainly that is the case sometimes, but the fact that, you can bring families in and people can, say goodbye to their loved ones, I think is really important. But you touched on a topic there about opening up the world and reopening. What advice do you have for businesses as they open of how to proceed in this new world, as far as procedures and cleaning and practices? Certainly, we know we can't all be as clean as Singing River Hospital systems, but we certainly want to shoot for that goal. So what's realistic and what can we implement?
Well, first I'll say in that regard, we are 100% in favor of reopening the world. A lot of people think that hospitals just want the world to stay shut down and to help avoid the spread. But unfortunately, what we're seeing is the precursor to many byproducts or collateral damage from the closing, whether it's people that have lost their job and now have, there are some serious mental health issues that are we're on the cusp of out there in the world. Second, there are people who are avoiding care, whether it's a stroke, a heart attack, or appendicitis. Dr. Roth diagnosed someone outside the hospital just the other day with appendicitis who probably normally wouldn't have gone to the doctor. So the sooner the world gets open, the better medically and health-wise it's going to be for everyone. The second thing I'll say that's not the direct answer to your question is we have actually found, again, through our contact tracing, that there's this term, safer at home. Sarah and I talked about misnomers yesterday on our Facebook Live, and that's a misnomer, because actually sometimes you're not safer at home. If you've got people visiting you at home, you're probably safer at work in a lot of cases. People are, because at work, people don't let their guard down. They're more likely to maintain their social distance, and they're more likely to wash their hands and stay more hygienic at work. And at home, they're just not. And that's just something that we've found with this. But as far as advice for businesses, our main advice would be that probably the most important thing you can do is let your employees know that you're going to take care of them and follow the federal guidelines that are out there, whether it's FMLA or taking advantage of the Payroll Protection Act, because what we also have found is the few people that got it at work is from a person going to work who's symptomatic or shedding and should not be going to work, because people need to work to make money, to make ends meet, and we understand that. But that's why that legislation is out there, to protect their job. And as an employer, if you communicate and explain that to your employees and implore to them, if you have symptoms, don't come in. And larger employers, and we're helping a lot of those with that, are doing checks, whether it's a temperature check. If you have the ability to do that, we highly recommend it, to check temperatures before people come in. Some are having people sign an attestation form that says, if you lie to us that you do not have symptoms, there's going to be consequences for that. If you see a person you're working with that's coughing, they should not be at work. And that gets into the whole mask debate. And technically they could wear a mask, but that's not a solution. If a person is coughing at work, they need to be sent home. That is one of the biggest things that we've seen through small employers. Someone was there, another employer, the boss suspected they were coughing, and guess what? They turned up positive. So I think that's the biggest thing that an employer can do. And there's other things. We'll have some things soon we're going to put out on our website that'll help sort of a pre-opening package for employers.
Another thing is if you're living or intimate close to a known positive patient, of those 240 so positives in Jackson County, that needs to be disclosed and addressed. How many times have we seen someone come in and these navigators are finding cohorts of cases, like 5 siblings that all live in 2 houses. So maybe the attestation says there's no one in your intimate contacts that's known COVID positive. I think there will be a role for testing moving forward. I can address that, I'm sure, in the question and answers down the road, on where does testing roll out to getting the business up and running again. The testing right now is better than it was when we started, and I think it will get a lot better come the end of May and June. Hand washing and distancing is the best
Wash
thing.
your hands. Don't touch your face.
And if you wear a mask, wear it right. A mask worn down here, you know, like the Lone Ranger probably isn't going to cut it. It needs to be worn correctly.
Well, that's a great segue into one of our questions from our attendees is, so to mask or not to mask, and what is the appropriate mask, and filters, no filters, you know, we're hearing all kinds of mixed information.
So we have I'll ask Dr. Roth to speak from a medical standpoint, but I'll start it out that we've said this over and over again. There's a false sense that masks are a panacea, that they will keep you from getting this, and that is completely untrue. An example is we have a patient here who was COVID positive, and he said, I don't understand how I got it, I wore a mask. Well, he was in a home with another COVID positive patient, and what we've learned, there was a study that came out 2 days ago that said if you are coughing and you have COVID, they don't understand the science of this yet, but the COVID droplets actually are more prevalent on the outside of the mask than the inside. So a mask will not save you in a lot of cases when you're in a home with someone that is COVID positive. You got to maintain your distance from them and keep your hands washed, free, and clean, and not touch your face. That's more important than the mask. And the Surgeon General, we believe, pretty much decided, and the country decided to go ahead and tell everybody to, you know, why don't you wear a mask, because people couldn't be trusted to go out in public that were coughing. If nobody who was coughing was out in public, we wouldn't need masks at all. But unfortunately, people go out who are coughing, and if someone coughs on you and they're not wearing a mask and you're not wearing a mask, there's a chance you could get it. So I guess our party line is that masks are important, but they are not the overall solution. And then if you're a medical professional, obviously you need to wear one, but you need to wear it right also. Right.
So, you know, people ask all the time, you know, if I walk into the parking lot at the store and I'm not going to have elbow-to-elbow contact, I'm not wearing a mask. If I go somewhere where I think someone is going to be coughing or trying to get into my space, I'll wear one. In the hospital, it's the safest place around. I do not wear it at my desk, but when I go into a patient care area, I wear the appropriate mask. If I go to an area of what's called aerosolization, I wear the N95. That's become a routine word in the community now. The most important thing is if you're COVID positive and you're out in public, that's the folks that should be wearing the mask and wearing it correctly. So that's kind of my mask thing. Now, I don't think it's going to be harmful if I see people walking down Beach Boulevard, you know, wearing a mask. If you want to wear it, more power to you. That's not how
Absolutely.
The disease is contracted when you're out in open space by yourself. It's a fomite, it's a hand-mouth face thing. It's not you're going to breathe in something from the community without intimate contact.
I'll add one last thing. If you wear a mask and you are around someone who has symptoms or is COVID positive or is pending a COVID test, and you wear a mask and you go into their house and visit with them, and you touch something they touched after they coughed on it, or you touch them, there's a very good chance that you're going to get it in spite of the mask. Versus, you know, a person who doesn't have a mask, that doesn't touch your face and keeps their hands clean, is probably going to be less likely to get it.
And the example is if you have a mask on and you're visiting a high-risk patient and you don't wash your hands, the first thing you do is reach to your mask to take it off.
You get it on your mask.
And you get it on your mask and it sits there. So common sense, hand washing is just so key, it's unbelievable.
Right. Yeah, the hand washing probably prevails over the mask any day for sure, and avoiding that contact with your face, which I found is a very big challenge for me. I didn't realize how much I touched my face during the day.
The average person touches their face 90 times a day. 90 times a day. When this first started happening, we'd go to a meeting and you'd look out and this was for the actual physical distancing, and at least a third of the people would have their hand on their face. And for women, it's tougher with the hair. I have found that shaving your head is a great opportunity.
So are you trying to start a trend right now? I'm not getting the clippers out, Lee. I'm not getting the clippers out. So you touched on some numbers, but how many COVID positive patients are actually in the hospital now?
Right now?
So this morning at Singing River, we have 19 in the system.
How many are in the ICU?
We have 7 in the ICU, 5 of which remain on the ventilator. We have some special needs communities. A lot of these patients, we have a kind of a hot spot in one of our communities, local nursing home that we're really working closely with to help mitigate that issue. Some of those are their residents. So we have 5 on the ventilator. Talking to folks across the Southeast United States, our numbers are pretty much following theirs. Our friends at Forest General have about the same numbers. I'm happy to report that ASHA, for the first time ever, has had under 100 COVID patients this morning in the hospital. So I think, I think we are, quote, flattening the curve, but we can't let our guard down. And I don't think something's magical is going to happen when we reopen the country that this is going to go away. I think we'll continue to have random COVID cases in our community until we come up with a very effective vaccine, which hopefully will be out in the fall or early.
And we've been able to discharge to home or to another, maybe back to a nursing home or something, 49 patients.
We have 49 discharges. We've had 2 that have been intubated. One went home yesterday. One went to long-term acute care. So, we've had 8 or 9 deaths, but we've had some victories also.
Great. So how are the doctors at Singing River keeping up with the latest developments in the treatment and the new pharmaceutical names we're hearing and drug treatment? How are you guys keeping up with that and administering or not administering yet?
So probably 4 times a week, myself, Dr. Bobber, who's our critical care doctor, Dr. McKenna, our infectious disease doctor, Dr. Wilson, who's pulmonary critical care, and myself. All of this is really what I call anecdotal. There are no double-blind, placebo-controlled studies that say Plaquenil and Zithromax works better than a placebo. So a lot of what we're getting is we're just taking it and running with it. So right now, we have decided as an institution that we're going to do this treatment, Plaquenil and Zithromax, if you're sick enough to be in the hospital. I'm talking to folks at UAB and ASHA pretty much daily now about what their best practices are. A lot of this is based on numbers of 20 and 30 and 40 and 50 encounters. And to give you an idea, a huge randomized trial is usually 10,000 patients. So a lot of these are very small numbers. So some things that you've probably heard about, I've already talked about the Plaquenil, Zithromax thing. Number 2 is convalescent serum or fresh frozen plasma. We have some volunteers that have tested positive that we probably will initiate that if we have a second surge. We'll use that. The Recidivir is an anti-retroviral therapy used in HIV. That data is not very clear that it's helpful. It may help you get out of the ICU, but it's not been proven to help you get out of the hospital and decrease mortality yet. But make a long story short, I'm proud of how our medical staff has reached out to all of our colleagues that are in hotter spots than us, and we've moved the pendulum pretty quick in terms of our treatment options.
Great. So our next question is it safe to go to the hospital for non-COVID treatment? Should we be worried? And that kind of speaks to, the folks with the appendicitis and things like that that you mentioned earlier.
I'll start, and then if you could add to from a clinical standpoint. So I would say absolutely yes. I firmly believe from what I see, the hospital is cleaner than probably just about any house in the entire Gulf Coast. And we have these UV robots that go into the rooms that with ultraviolet light kill any possible bacteria of any kind. We already, before this pandemic, we were voted #1 in the state in patient safety and medical excellence. And that's because of our environmental services team. Terrence Holland and the team there, a lot of hospitals outsource that. And we brought that in-house about 2 years ago. And that's what helped us get our cleanliness scores to where they're so high. As somebody said yesterday, I wouldn't do it, but you could eat off the counter in the emergency department. That's how clean it is. And we've just out of an abundance of caution with COVID, we've doubled some of the wipe downs of surfaces, but it's absolutely positively one of the cleanest places you can go is in the hospital.
I'll add to that something that's a little bit technical, but we moved very quickly to make all of our COVID units negative pressure, which means that engineering-wise, there's a large suck of wind that keeps everything in that patient's room or in that unit. Randall Cobb is our engineer, and within 4 days, we made 30 of our beds, 12 of our ICU beds, and 25 of our floor beds in negative pressure. I don't think anybody else moved that quickly to do that. And that's reassuring for a lot of people. A, the patients. B, it makes me feel better that we're minimizing the exposure of our nurses, who are the real heroes in what we're doing today. And then our other guests that are having elective things done, they need to know that they're not going to be next to a COVID positive patient. And by walking that hallway, if you open the door, you feel like the little bit of hair I have left, it kind of gets sucked into those patients' rooms. And we move very quickly to do that. It is a very safe place to get anything done. In fact, it's probably safer now than it was 4 or 5 weeks ago.
Yeah, it's incredibly safe. And the bigger issue is we have, as we alluded to earlier, we've witnessed cases where, you know, people have put off something when they have stroke or heart attack symptoms. And I'm not saying that to try to drum up any business. We're a not-for-profit. We're here for the community. We're not in it for the money. We're here to serve and meet our mission to improve health and save lives. And if somebody's having stroke or heart attack symptoms or appendicitis or other issues, they really should consult the ER or their doctor, and we're here to help with that. We have learned that in others, we talked to some of our colleagues in another city yesterday, and in that city, which is not in this state, their death rate from non-COVID related deaths year over year is up 40%.
Wow.
We've looked at some numbers on the coast, and it's hard to get statistics. We found one moniker that shows that our death rate might be up about 4%, but that's concerning. And we want people to come get the help that they need. And we're here, and we're safe, and we're clean, and we'll take care of you if you got a problem.
Great. So we have a couple of questions in the queue about what are the biggest learning events and takeaways from this experience that we could take forward to the future. We're kind of, you know, in different capacities, everybody's doing on-the-job training with this experience and trying to figure out what's the next, or what did we learn and how do we get better for it?
Well, I'll start. What I learned is I was already proud to work with these people, and I learned it takes a strong person to become a nurse. You know, you've got to, everybody can't do it. And some people learn that in life, but, you know, there's a thing I like to say that, you know, a lot of people, everybody wants to make a difference in this life and make a dent in the universe and make a difference. And some people go their whole life trying to do that. A nurse never has to worry about that ever. And that has been so prevalent during this. I have seen it. I've seen people rise up. We have had people go back and forth between hospitals, back and forth between units. We have not had one single person complain. They have risen like heroes. I think the lesson learned is that the strength, grit, and commitment of people who become nurses is just unbelievable. And you know, doctors and techs and phlebotomists, all of them. It's been absolutely incredible and awe-inspiring. We've also learned some things. I'll tell you, there's some not so people good in the world. You know, we used to buy masks for 48 cents a mask, and I probably received at least 24 emails and a dozen calls about somebody who was getting masks, probably from the Mexican drug cartel or Canada, for $7 each in some cases. We didn't buy any of those, and there were a lot of people that tried to take advantage of the world in this situation. But I guess in hindsight, the world needs to be a little better prepared for some of the personal protective equipment thing, like gowns and masks. We're very fortunate. Our materials management person, Joseph Foster, jumped on this, and we got out ahead of a lot of other friends of ours and systems in Alabama and Louisiana before this happened. So we've been in good shape, but it's, as you know, it's been a national problem. But that's probably a lesson learned. And the last thing I'll say, even though I could talk about this for probably an hour, is that there's been a lot of silver linings in this. We took a chance on in this market in growing our pulmonary critical care team. We now have 5 full-time critical care pulmonologists on our team, and doing that before growing the Pulmonary Hypertension Center of Excellence like we did, there's some risk there, and it turns out put us in a very good position to deal with what happened here with us experiencing a higher percentage than a lot of other counties. So So that's been a silver lining, seeing our critical care team step up and a lot of other teams. There's we got a whole list of silver linings.
So for us, I've learned the cream rises to the top. As soon as this broke out, I got a call from one of my pulmonary doctors who's military trained, and he says, "I'm coming into work tomorrow." And I said, "Well, you're not supposed to start till Monday." And his quote was, "I've lived my whole life to do this." And he came in, didn't ask to get paid for it. He was right on the front line.
Been here every day since.
You know who your friends are when something like this happens. We've had nurses who have worked like us 45 straight days in these units. That's pretty good. Other great things have happened when we made a kind of a mantra on our own that nobody's going to die alone. And a lot of these families are scared even to come in at the end of life because they're worried they may get COVID.
Our first patient wasn't even from here. She was from Michigan, and her husband couldn't travel, and so they did everything via Facebook.
Not to be sappy, but we have several where these patients' last moments, their hand was being held by one of our nurses, respiratory therapists, and that never gets easy, and that was a beautiful thing that we've done. The last thing is, from a medical profession, is we had to move quickly. The word we use is fluid. I mean, initially the word we got from New York was intubate early and get them on the ventilator, and that's going to save their life. And then about 8 days later, Isla Bobber says, "You know what? Nobody's come off the ventilator. Maybe if we don't ventilate them and try to use high flow oxygen." And our first discharge to home was someone that we would have intubated. It has changed, just like the recommendations from CDC. So we've moved very quickly for a regional, small county hospital. We've done some great things.
It's also increased the awareness of the importance of vaccinations. I think we'll have a lot less flu cases next year and have a lot less flu deaths because people will get the vaccination. And probably one of the biggest silver linings actually is the governmental red tape surrounding televisits was eviscerated. And they're not going to be able to go back. And we've been pushing for that for a while. And so that's probably one of the greatest silver linings is now televisits are easy. A lot of people can do those. You can't do a televisit on everything, but the things you can, it's really put us in a good position there.
Great. So we're also thankful to the doctors and nurses in our community and of course all over the country, but just in this case of Singing River, kind of what's the morale and what's the feeling there?
I think our morale is great. We have, I say it all the time, I call them our fearless warriors. We had people that just went straight to the front line and they were born for this. I mean, they just, do what they do. And it's been truly awe-inspiring to watch these folks as heroes. And we've done a lot of unique things. We put hero signs in we put out 2,520 something hero signs in our team members' yards, and we've had the community and the churches have stepped up to cook for them. You've got our military friends who we love at Keesler did the flyover in Ocean Springs. They're going to do it for Pascagoula on Tuesday, I think, around 2:30 on Cinco de Mayo. They're going to do a flyover there. Just the way the community has stepped up, that's helped the morale indeed, because it's tough. I mean, it's, there's not many people that work 45, 50 days in a row like these folks have had to work, and the sacrifice. I mean, in the ICU, some folks have, who have a family have had to separate from their family, but.
Yeah, I think the morale's fine. I mean, I think what's also helped is, I'm not a military person. I wish I could have served the country. But a lot of our healthcare providers, doctors, nurses, are really starting to appreciate the little things. Being told thank you for your service, it kind of sounds kind of corny, but at the end of the day, it means a lot. So what the community has done to recognize the folks that have put themselves, and I'm not saying it's the same thing. I never would compare what I've done to what somebody has done in Vietnam or Iraq, but I think it's nice, especially for our nurses, to walk to McAllister's and have a lunch, after they've worked 12 hours, and they say there's no charge, thank you for doing what you do. Those little things go a long way.
I agree. I've been inspired of how the community has rallied around our healthcare professionals, and everybody there has obviously risen to the top. I think Katie is going to bring on our CEO, Ms. Adele Lyons, for a few minutes. We're still taking a few questions. If you guys would like to type those into the Q&A, Adele has a few chamber remarks she'd like to make.
Hey, good morning, Lee, and just want to say thank you to you and your staff. Y'all are a very active chamber member, and we appreciate you all. It's really been great information to share to the community, to our members, to business folks, to just keep up with what's going on, how they can best take care of themselves, take care of their employees and their families, so that we do see a way out of this real soon. And just really want to say thank you for your time today and for your continued dedication. Appreciate y'all.
Thank you very much. That's what we're here for.
Thanks, Adele. So a few more questions we have. So one of them is in regard to contact tracing. Is the hospital doing this, or is that being run by the state health department? And kind of what does that involve?
We are. It's something I'm very proud of, actually. We have a daily rhythm meeting that we started back on March the 9th, our first one. We've had one every day since. And we, several weeks ago, before it was even advertised anywhere on the news, probably about 5 weeks ago, we decided that in order to slow the spread or smash or bust or make the curve smaller, the only way to do that was to do contact tracing. And so we put together a team of people, navigator, we call them navigator / epidemiologist / contact tracer / nurse. And some are outpatient nurses we assigned to this. And it is absolutely had an impact. We have been able to find the source of many of these, where it started, and educate and inform families. We've worked hand in hand with the health department, but let's face it, I mean, they're overwhelmed. They don't have enough people for this, and we can't fault them for that, because there's not enough people to be on a staff prepared for this. They'd had to have 10 people in every county. So we sort of did it ourselves, formed our own mini extension of the health department, and we've traced to the greatest extent we can every single case. And we've learned a lot from that. We've learned from that the main source in over, I think it's like 74% of the cases, the exposure came from a family member through a social gathering such as a church, a funeral, or people doing a painting or working on a shed together, things like that. It's usually from family or a neighbor. And that's why early on our message was, stop the visitors, stay away from your family, don't go visit grandma. And that's a result, that message was a result of what we learned right away with contact tracing. So we think contact tracing is very important and paramount. And I think when this thing is over, there's going to be a whole new protocol for contact tracing, and we think will help write part of that book, hopefully.
Great. So how many tests are being performed per day? And I imagine this has changed a little bit with clinical permissions to do testing, and kind of what is the capacity of the hospital to test? How many tests can you do a day?
So our number of tests per day actually has been, stair-stepping down as we seem to be kind of on the downhill slope of this whole thing. But at one time we were tested over 100 a day. Now we're, some days we'll have as few as 25. But ultimately, we've got extensive testing ability. Our lab director, Virginia Mosley, is one of those people that she has literally worked every single day since March 9th. I bugged her twice on Easter, about things, and she's been relentless in seeking out every opportunity. We don't just use one manufacturer. I will say AEL has been a great lab partner. We converted them for other systems and benefited greatly from their quick one-day turnaround. We now have the BD Max program that we can get results back pretty fast, as well as the Abbott ID Now, and those have all been a benefit to us in those relationships with those vendors. But I would say we have no known limit of testing at the moment.
Great. So do patients ever fully recover from COVID, or are there some long-lasting symptoms that can stay with them or impacts?
So a lot of that's unknown because, like I said, this started in November of 19. But I will share a couple of anecdotal stories. I've had several patients who have come to the ER who were COVID positive. We swabbed them. They had abnormal chest x-rays. They had low oxygen levels. And I sent them home because they were otherwise healthy. And they're texting me every day, and they're 20, 30, 40 days out. I think they will have no long-term sequelae or side effects from having COVID. The flip side to that is there's no doubt in my mind that our patients who are on the ventilator for 30 or 40 days, they develop what's called ARDS, adult respiratory distress syndrome. And we see that in trauma and pancreatitis and other diseases. And their lungs get stiff, and they probably will end up with some pulmonary deficiencies after they leave the hospital. And that's why it's so important for us when we get back to normal medicine to make sure we plug them in with our pulmonary physicians as an outpatient so we can make sure that their quality of life continues to improve. What the data has shown from mainly South Korea and China is the vast majority of these folks will fully recover. It's the comorbid patients who have all the other things that we have to pay attention to: kidney disease, hypertension, diabetes, obesity. Morbid obesity, we're in our tracer group, the biggest common denominator in our patients who had over 15 days in the ICU is morbid obesity.
And corollary to that, the WOX story on Captain, what's his name? Captain Gary, who we love. He had comorbidities, but he had diabetes, and otherwise he was physically fit, and so he overcame it by being in a better position than some folks who have let that go a little more. So
Great. That's promising, a promising outlook for all of us. So, you talked about folks coughing at work, and how do you distinguish as an employer between someone who has a chronic respiratory issue like asthma or allergies to someone with COVID, and, how do you weigh that out?
I think, if I see somebody who has a little bit of a slight cough in our system on the front line, I may go up to them and ask them, are you living with a COVID patient? Are you having fever? I think the travel part of this is not very relevant anymore. I mean, it's community-acquired disease. So I'll just ask them, do you have a COVID exposure? You're taking Allegra for your sinuses. So a little bit to that point, I just don't think if someone coughs once that we're going to send them home. But there's a difference between someone who coughs every 2 or 3 minutes, even in their elbow, than someone who has a random sneeze or a cough. So that's kind of the way I would approach that.
Yeah, I think a person who, if we're in a meeting with someone and we hear someone cough, if they swallowed water or something wrong, that's one thing. But if we've heard them cough and maybe they've had exposure, if there's any other reason to believe they need to be tested, you're going to get tested.
Agree.
Great. Do we expect a resurgence of the virus later this year, and are the hospitals going to be prepared for that should it happen?
We'll, first of all, we'll be prepared. I think the days of us not being prepared for something like this are behind us. We're prepared for Ebola, Zika, and it's like preparing for a hurricane that doesn't hit. This hurricane hit. We'll be prepared. As a physician, I do think that we'll be dealing with COVID next year and the year after. I hope we don't see a resurgence, either we call it an Easter resurgence or a post-opening resurgence. If we do, we'll be ready. I do think more people are going to get passive immunity just because it's in the community, and it may not be as, I think we have to protect our patients and our citizens who are more susceptible. We have to focus on the 65 and over, nursing home, elderly people, and let's protect and keep them safe. We have had some young people who have had COVID, but it's not Drew Brees, it's not Tiger Woods. Right. Those folks don't tend to get as sick as our people have been. I hope we don't have a resurgence. At the same time, Lee mentioned it earlier, we are having people that are having definite sequelae of COVID that never had the disease because they've lost their job, they're losing their insurance. Can they send their kids back to school safely? They're running out of daycare options. And we need to prepare for a tier-wide reopening and doing it right.
Yep, couldn't agree more.
Absolutely. So I have a final question for you. We're now hearing about antibodies. Do you see a world where everyone is tested, either to see if they've had it, have built up antibodies, or the hospitals can use that plasma for treatment?
Yeah, I do think there'll be a day where we test for antibodies like we do after you get immunized for varicella or you get immunized for rubella titers. The technology is not there, so I've done a lot of research into this because we're getting asked every day. Right now, what's offered, nothing's FDA approved, number one. Number two, what's offered now is I can screen you for IgG for coronavirus, but it may be cat, dog, bat coronavirus and not COVID. So you may be leaned into a false sense of security if your IgG is positive. I think in a month or two, we're going to have a very good antibody test, and hopefully we're going to fast track through the FDA a vaccine. I will tell you, Lee and I are going to, we agree with this. I just hope people get vaccinated because everybody's begging for a vaccine, but it's amazing how many % of people don't get the flu shot when I know it's not perfect,
Right.
but it's really better than nothing. Educated people that will not take a flu shot because they get the flu. We fight through this pandemic and we get I think we're going to make it mandatory. I hate to say it, we should.
We will. If there's a vaccine, it will be mandatory to work in here in healthcare. And I agree with him 100% on antibodies. It's, as we say, we will serve no antibody before it's time. We advise people that want it. I mean, we can do the test.
Absolutely.
But as has been shown out there, there's I think it was the city of Laredo bought all of these tests, and it turns out they were 20% effective. I mean, you could flip a coin and have a better outcome than that. It creates a lot of false positives. There's a lot of issues about the timing of it and what it tells you based on the timing. There's so many issues surrounding it. It's not FDA approved. We believe that we should wait and hold just a little longer until the best ones that are in the latest ones were in the 60s. When it gets to the 90th plus percentile, our pathologists are meeting with Dr. Roth every other day, and we believe that that's just not quite the right time yet to go widespread antibody testing, unless you're in a clinical trial or a test environment or something like that, which we're not. So we're prepared for it, and we hope to get there, but the technology, the test is just not out there in the world yet that's accurate, and we believe that people would be wasting quite a bit of money in doing that. There are some situations where you can confirm another type of test or an actual COVID swab, but those are rare, and for the most part, we don't think it's quite time. Might be tomorrow or it might be next week, and we'll let the world know when we think it's ready for that.
Great. Well, we appreciate you guys coming on. I could hold you here all day and ask you questions about this. I'm just, appreciate the direct information, and I'm going to turn it over to Katie to give closing.
Mr. Bond, Dr. Roth, thank you so much for being here. And I think, Mr. Bond, you wanted to actually make some remarks about your employees, thanking them.
Well, I just wanted to be sure I had an opportunity to say thank you to people ask me what I want to talk about on COVID, and it's mainly I want to talk about our team members. Our core values have been really deeply displayed here, and they truly are heroes, and I absolutely could not be more proud of what they have done. And I just, as always, a huge, enormous thank you to the team that we are blessed with here at Singing River Health System. So that's what I wanted to be sure I had an opportunity to say.
Absolutely. And they are our heroes, all of you. Thank you so much for what you're doing and being on the front lines. Words will never be enough. So whatever we can do as the chamber and as a community to help you, we are backing you 1,000%. And we can't thank Singing River Health Systems enough for not only being a member, but just being such a huge supporter of us. And for both of you taking the time today to come speak to the public, speak to our members, and just have them the opportunity to actually talk to the professionals. Thank you so much for being here. And thank you everyone who attended today. Please be on the lookout for our events next week. You can find those events on our Facebook page, Mississippi Gulf Coast Chamber of Commerce, or on our website at mscoastchamber.com. And on that note, I hope everybody stays happy and healthy. Mr. Bond, Dr. Roth, did y'all want to do some sign-offs?
Well, I'd say number one, stay Singing River strong is what we always say. And if you look back over his shoulder, we are Singing River, and songs are part of our brand. And I'll lean this way a little bit. Everything's going to be all right. That's our theme song.
That's
Stay
right.
safe. Thank you all for your time.
Appreciate it.
Thank you all so much. We appreciate it. Everybody have a great day, and thanks for joining us. We'll see you at the next one.